First. Okay. Oh, man. All right. All right. Let's keep going. You were always supposed to do a case, but it always seems like such a waste of time when you only have a few. Anyway, so 35-year-old, wheezy pneumonia, gotten worse over the past 4 years. Wakes up with shortness of breath 3 to 4 times a month. Has an albuterol inhaler, which she uses 5 or 6 times a week. And the questions that should be going through your mind is, of course, based on history, because you don't have any PhDs. What's your diagnosis? If you have a diagnosis in mind, what are the risk factors? How would you classify the severity of this disease? And is there a treatment appropriate currently? Well, I'm going to try to answer these questions throughout the next 45 minutes. But as you probably know, this is an asthma lecture, so she probably has asthma. So I love asthma. Asthma is, it's one of those diseases that you think when you first take care of it, you think, oh, it's so easy. They just wheeze and you give them an inhaler. It's all done. It's really complex. It will screw you over so many times, and you will try and be thinking, oh, I'm treating some COPD, or I'm treating something, and then it turns out to be asthma. Or you think you're treating asthma, it turns out to be something like an intratracheal tumor. And so, if nothing else, this is not going to be the complex asthma lecture. That comes usually in January. But there are a few things I'm going to address because there's been some changes in the last 2 years in treatment, and they're pretty significant changes. And then hopefully I'll kind of give you a little bit of background so you know why this turns out to be a pretty interesting diagnosis. So this used to be me. I never was on TV, but I used to think, oh, someone has wheezing, they're not smoking, even if they did smoke 2 months ago, they must have asthma. Obviously not true. More complex, or people with a little bit more education realize that you have to have the right risk factors, you need the appropriate testing, you have to have the appropriate course. A lot of times asthma is about history. And then of course, are they responding to the therapy? And this is my pet peeve. You know that a noisy throat is not a wheeze. I swear every ER doctor in the country listens to, they'll come in and I say, I heard the wheezing across the room. I'm like, well, then it's not a wheeze, it's stridor. And so you have to have a stethoscope to hear a wheeze. Most of the time. Sometimes you can hear the vibration of a wheeze without a stethoscope, but if it's in the throat, it's stridor. And I wish they could mention that in the ER curriculums. So asthma has a few funny little epidemiologic twists to it. It's difficult to estimate because there's so many definitions, but we do seem to see increasing prevalence. In the United States, we say 8% if you just want to have a good round number, but there's a lot of subsets, subpopulations. It's higher in children compared to adults, 8.4 to 7.7. Childhood asthma is more common in boys, but as children age, the women take over and pass the men, and adult asthma is more common in women, 9.8%. And then in African Americans, it tends to be 10.1%. The most, the subgroup that really gets screwed over are the Puerto Rican Americans. Mexican Americans seem to have some sort of something protective, and we're still trying to figure it out. They only have a prevalence of 5.1%, but if you look in Puerto Rican Americans, it tends to have a prevalence of 12.8%. Why? We don't know, but it's kind of interesting. And you see it even in Cleveland, where we don't have the highest number of Puerto Ricans in our community. They're the ones that they do pop up sometimes at UH, not at the VA. They'll pop that up with asthma. So and in Chicago, it was really common. A lot of, something about the Caribbean islands, it does seem to be. And there's a study called the SOUL trial, or study of Hispanics, and that we should start seeing data from there coming up pretty soon, and it looks into Latino subgroups. Kind of a little interest of mine. So this is, if you had a slide of a biopsy of an asthmatic, you would see something like this, obviously not completely like this, but this is mucus with your infiltrate These are eosinophils. It doesn't have to be eosinophils. It can be neutrophils. Sometimes we'll even see lymphocytes. We do not tend to see mast cells, but this is where your infiltrate is. This happens to be an eosinophilic infiltrate. Here's your epithelium. This is your basement membrane. It's distorted, probably over inflammation, but you'll have to trust me, this is thickened more than usual. Below the basement membrane, we see elastin fibers that are interrupted. And that again is related to the main component of the pathology, the pathophysiology of the disease, which is inflammation. Later on this month, 26th, I think we're going to be talking about the classic studies of asthma. I think we're going to look at, there's a journal, there's a study from 1994. I have to make sure I give Aria the right citation, but it's when they finally figured out that the underlying disease component was not bronchospasm, although it's certainly a big problem. It was the inflammation. It's a disease of inflammation. And we will talk about that. So just back to the cell here. Bronchial tissue is infiltrated with a variety of cells. It can be eosinophilic predominant, neutrophil predominant, mast cells and lymphocytes. Actually, mast cells they're there, but they're not as common. Remodeling of the lamina reticularis under the subepithelial basement membrane may contribute to stiffness of airways, and we don't. One theory is that maybe that stiffness was protective at some point. There's smooth muscle hyperplasia, which narrowing and obstruction, and then mucus gland and goblet cell hyperplasia, which means, of course, your patients have increased secretions. This is actually, I actually used my great PowerPoint skills and copied, drew this little picture, but it's modeled on a cartoon from the Global Initiative for Asthma, GINA, which is kind of like the gold of asthma. But basically you have some sort of risk factor for developing asthma. So that's the substrate. If you think about the two-hit hypothesis that we hear about so often, there has to be some sort of underlying issue with the patient. We'll talk about common ones, but let's just, for example, say that they have underlying atopy. And that sets up an environment of inflammation, which causes some hyperresponsive airways. Then along comes a trigger, and the trigger causes the airway to react, usually bronchospasm and maybe a cough, and then you have airway obstruction, which of course causes your symptoms. These risk factors, we always think about, of course, we think about atopy, but there's also, so there's secondhand smoke in childhood. That seems, when someone's an adult onset asthmatic, that's not there. This is my impression. It seems to be a very common underlying risk factor for asthma. Bronchiolitis in the first year of life, most common virus is RSV or rhinovirus, so don't get near me and give your kids, if you have kids, my RSV. Atypical pneumonias, chlamydia, and mycoplasma. There are genetic predispositions, gender, as you mentioned, females, race or ethnicity, so African Americans, Latino subgroups, obesity, occupational sensitizers. The one that you always hear about are those volatile organic compounds in varnishes and paints. And then finally, hygiene, which is sounds kind of weird, but you may have heard of the hygiene hypothesis. I remember I was a not very good fellow, and I was forced to go to this grand rounds. We didn't go to grand rounds that much at my fellowship. We tend to do our own little thing, but they said you got to go to this grand rounds. It turned out to be a lecture from the guy who first proposed the hygiene hypothesis. So this, of course, was very important for anybody interested in asthma. He had been in China and noticed that the Chinese who lived in the cities seemed to have an environment of widespread use of antibiotics, Western lifestyle. They had an urban environment, so a lot of particulate matter. Their diet tended to be high in fats, low in vegetables that had certain antioxidants, and then they had a lot of aeroallergens. This is tended to predispose their lymphocytes to be a CD4 phenotype with a Th2 receptor. which is a balance that tends to lead towards allergic diseases, including asthma. As opposed to this subgroup, there were groups that tended to live in the country, that had a presence of older siblings, early exposure to daycare, viral infections, farm environment, tuberculosis. Doesn't sound like fun to me, but they actually had a somewhat protective immunity. There was a secondary study that found out that of the subpopulation, and this was not just in China, but in Kenya, they found in Kenya the most protective factor was living with a pig. So live with a pig, you guys. So then in this environment of risk factors, and then along comes a trigger. These triggers are, you can ask your patient, what triggers your asthma? What makes you wheeze? And they always tell you all kinds of interesting things. They love to say the weather. And weather, if you look down here, if humidity can be a component, but allergens, environmental smoke, I mentioned organic fumes, industrial pollutants, particulate matter, infection, humidity, emotional states. This is a real thing. Emotional states, hormonal states. So you think about your pregnant woman who's basically controlled, and then she gets pregnant, and then she's in your office saying, "I'm using my rescue inhaler, 5 times a day." GERD is a big one, and then of course exercise and exercise-induced asthma. When I lived in Chicago, they were trying to close down, there are 2 coal-burning power plants in the middle of Chicago, and all of the prevailing wind, those particulates went straight toward the Latino communities with the prevalent wind. And so they had this amazing sign, and they had this little boy who was taking an inhaler. He was not Latino. Of course, they made this like little blonde boy as their poster child, literally. And but they said the city of Chicago has found a wonderful new filter for the industrial pollutants being in the middle of the city. His name is Tommy. Because basically these children are breathing this air. And I thought they actually did finally close down those power plants in the middle of the city. So what characterizes asthma? Variability. And this bronchial responsiveness or hyperresponsiveness varies over the course of years, over the course of days. Sometimes it's completely absent. Maybe it's relevant, but the patient doesn't notice it. Sometimes you think the patient has allergic rhinitis because there's a lot of overlap. And it's not necessarily, hyperresponsiveness is not necessarily the most clinically prevalent symptom. As I keep mentioning, that infiltrate, or rather the inflammatory cell may or may not be present, and eosinophils and neutrophils tend to be the ones we pay attention to the most. And that is in either the sputum or the serum. And then sometimes it's just a cough, which can really fool you. If you're trying to get a biomarker of asthma, sputum is the best one. All the studies were done on sputum. Guess what we can never get anywhere? UH, VA, Cleveland Clinic, it's really hard to get sputum cell counts, which is a shame. But it can be, it's a very helpful biomarker in asthma. This is, believe it or not, I found this on the web last night. This is something that makes a sound like a wheeze if you blow through it. Does anybody online know what this is? Any hunters in the group? Anyway, it's apparently when
Is it a duck call?
It's not a duck call, it's a deer call. Apparently when deer wheeze and cough, it's like a sign of relaxation. And they say, I don't know what it sounds like, but they wheeze and cough and then they start to eat, and other deer will be attracted. If you're not a deer, a wheeze is bad though. So cough, wheeze, shortness of breath, and chest tightness, you guys all know this. Episodic in nature, associated with a trigger, worse at night or early in the morning. This may be the humidity playing a role, but there certainly is a daytime and nighttime variation. And then pay attention to this, typical comorbidities. GERD, usually non-acidic and non-symptomatic. So your patients will say, I don't have any GERD, I have no problems, I don't have any. Well, they still could have GERD. And you have to consider it if their asthma is uncontrolled. Sinusitis, rhinitis, they always complain about that. Obstructive sleep apnea, and then even if they don't have obstructive sleep apnea but they're obese, there is a signal of asthma. And then vocal cord dysfunction is a huge comorbidity. And again, I'm telling you what you already know, but once you've done your history, you have a presence of a risk factor, presence of triggers, and your exam demonstrates wheezing, but not always, or a cough. Then you proceed with your testing. You can do spirometry with bronchodilator challenge. Most recently, in the 2020 update the guidelines, they actually are now accepting a FeNO, fractional exhalation of nitric oxide. It's a conditional acceptance, but it can be used as a diagnostic test. If you have normal spirometry, you have to do a challenge. Methacholine, mannitol, these are two irritants. If they're inhaled, they can induce a bronchospasm. And then finally, if you have an extremely reliable patient, I've only known one, and they show you a peak flow journal, and there's variability of 20% over the course of 2 weeks, that actually is considered to be diagnostic too. And then once you've arrived at a potential asthma diagnosis, you still need to consider asthma imitators because there are a lot of them. Just continue with diagnosis. There are adjuncts that can be helpful but not necessary. Sometimes we get IgE levels, serum eosinophils. This helps us determine the phenotype of the asthma. If this is negative, it doesn't mean they don't have asthma, but there's a lot of neutrophilic asthmas out there. Alpha-1 antitrypsin testing, if they seem to have emphysema or if they're at risk of emphysema. If you're lucky, induce sputum cell counts. And then we mentioned FeNO before. And I guess I got a little repetitive here. This is a conditional recommendation in the context of other data. So a little note about spirometry and peak flow. So peak flow, which is actually, it's still recommended, the heart-lung blood, the Heart-Lung Blood Institute, which is a subset of NIH that we, as lung doctors, kind of fall into, they actually have developed the National Asthma Education P program. I can't remember what the other P is. NAPP. They actually, in 2006, kind of bolstered the use of peak flow. And it was very controversial because peak flow is actually useful for monitoring obstruction, but not so great for diagnosis. And it actually overestimates severe obstruction, underestimates mild obstruction. Some of those patients with really good accessory muscles can just blow straight through peak flow, even if they have bronchospasm. And then, of course, there's individual variation in using the peak flow meter. Usually, it's best to determine an individual's baseline, and then only when the patient is completely well controlled and completely asymptomatic. So, what's the point of peak flow? Well, it can help asthmatics detect they can detect their breathlessness. It's something that I do not understand, but there are asthmatics that seem to be asthmatics, particularly from childhood, but it can be an adult asthmatic too, who just don't sense their own breathlessness. And so a peak flow meter, if they need something objective, it can be a means for them to notice that they're breathless and their peak flow has decreased. I'll never forget, this was one of my fellow med students. So this is an educated person. She'd already done her asthma rotation, or well, her pulmonary rotation, although they didn't talk much about asthma there. And she told me that, I knew she had asthma, and I knew she was, maybe not the best controlled asthmatic. She said that she told me she came in one morning and said, I woke up on the floor last night. And I said, what are you talking about? She had passed out because her asthma was so poorly controlled that she had essentially become, it's unclear exactly what happened, but she may have become mildly hypoxic, or she may have hyperventilated. It's hard to know exactly what happened, but an educated woman could not sense her own breathlessness. Thank goodness she then went to just one of the local family doctors, and they said, okay, you need better control. They gave her a controller inhaler. At that time, the guidelines said start steroids, and then she used her inhaler, rescue inhaler separately, and she was much better controlled. But this, even a very educated person may not sense their asthmatics, especially if you work with pediatric populations. Those pediatric kids, those boys, they'll want to play until they fall down because they don't sense it. They just don't sense there's there. And so sometimes the peak flow meter can be your aid and showing them that yes, you are breathless. Yes, you do need more control. Here's a curveball, cough variant asthma. And this is probably responsible for most of my, no, I can't speak for anybody else, for most of my misdiagnoses of asthma has been cough variant asthma. Thank goodness that pheno has come into more common use because pheno is a very helpful way to diagnose cough variant asthma. Just a few stats. Usually people believe that this is a chronic cough. They don't sense, again, for whatever reason, they don't sense any bronchospasm. They don't necessarily wheeze. Sometimes they do. But in non-smokers, it's 24 to 32% of chronic cough. I mentioned that they don't always have a wheeze, but they frequently have a little dyspnea. Atopy seems to be part of this particular type of asthma. They do have serum eosinophilia and elevated pheno. In biopsy specimens, eosinophils and occasionally neutrophils are elevated. In this one, mast cells are not elevated. These are things that we're still figuring out some of the reasons why. But pheno is a lot easier to do in, you have your patient do your pheno right there, then spirometry. And if you can get the patient to succeed in a pheno test, if they're above that 35% or 38%, depending, threshold, it's very clear they at least have eosinophilia. And it's, then you can actually proceed with treatment. Now, pheno, as I mentioned, can be useful for diagnosis and for therapy guidance, i.e. steroid responsiveness. But a definitive diagnosis of cough variant asthma can only be made with a documented resolution of cough with asthma-specific treatment. Because as you will see, and I will talk about ad nauseum, there are a lot of asthma imitators out there, including cough variant asthma. There is one little sneaky entity called the non-asthmatic eosinophilic bronchitis that will make your pheno high, even though you don't have cough variant asthma. And that's the one you have to either get, it's hard, it's very rare, but it's very hard to distinguish from, cough variant asthma. You technically need to go in and do a biopsy. You can do cell counts. This is why that when you have a chronic cough that does not respond to inhalers or GERD treatment, whatever, we will sometimes do a small course of steroids because steroids is the treatment of non-asthmatic eosinophilic bronchitis. I've probably seen that too, and I didn't diagnose it, just so you know. It's hard to catch. Speaking of asthma imitators, there are a lot of them. I'm not going to read down this list, but just realize everything. There's a lot out there. Sarcoidosis, interstitial lung disease. This is why we want to get chest x-rays in chronic cough. Vascular rings, PE, of course, Church-Strauss, or Church-Strauss, I shouldn't be using eponyms, but now I'm blanking on the eosinophilic, blah, 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 blah. Anyway, you know what I mean when I say Church-Strauss. So a lot of imitators, don't forget COPD. This is my favorite slide of an asthma imitator. This was a young woman, actually, no, I'm sorry, she was a girl, about 12 years old. They thought she had asthma. They kept trying to give her inhalers. It didn't work. Finally, someone, and this is, of course, this was her PFT, poor girl. So she's trying to do a PFT and she basically has no flow, especially when she had a forced, she did a forced flow. Finally, someone got a CAT scan and they found this little intratracheal or intrabronchial tumor, which is basically acting like a little ball valve. She tried to breathe out and the little tumor would swing up and close her trachea. She'd inhale, see, she can inhale no problem. and it would swing out, and she would be able to inhale beautifully. She was resected, and these are her PFTs afterwards. So there are some very interesting imitators out there. So management. This is where some of the changes have been made. I hope I have time to talk about this. Oh, of course I don't. 15 minutes, so I'm going to get management in 15 minutes. First, evaluate underlying asthma severity, assess control, and I use the rule of twos, but you can use different questionnaires if you have a very reliable patient. Peak flows, and then just realize that you may need to institute some non-pharmacologic therapies, trigger ID, and control. Yeah, Aziz is in the MICU. So of course we do have severity symptoms. You don't need to memorize this. We don't seem to use it as much because we've been a little bit better in asthma about moving towards clinical patient-centered outcomes. And just realize, even if you are using a spirometry for severity assessment, you need to have symptoms if you have mild, moderate, or severe asthma. If the patient doesn't have symptoms, we don't really care about their spirometry. The only one that may not have symptoms is mild intermittent. And of course, triggers. Because it's so variable, you could have a patient with moderate asthma one visit, and then 2 months later they have mild asthma. So this changes, and perhaps that's why we've moved so much to patient-centered outcomes in asthma. I like to use the rule of twos because it's easy. I like everything that's easy. Does your patient have symptoms, or use their short-acting short-acting broncho beta agonist more than 2 times a week? Does your patient wake up at night with symptoms more than 2 times a month? And does your patient use more than 2 metered-dose inhalers or HFA canisters in 1 year? If yes to any of the above, your patient is not well controlled, or you can use a questionnaire. At UH, they use the ACT. At the VA, I have the ACT printed out in my little folder of printouts, but it's a lot for the patients to use. But this is what it looks like, the asthma control test. Sorry, it's a poor picture. When you assess the score, have the patient assess their own symptoms. Just remember that a higher score means better control, as opposed to some of the COPD questionnaires where a higher score means worse control. Usually we like it to be above 14. Once it's above 20, it's really well controlled. 30 is the maximum. So therapy is changing, so you have to keep an eye on it. This is from the 2020 Global Initiative for Asthma. The big change is that we are using more steroids in mild intermittent asthma. They have finally, Gina finally just, they pulled the trigger, and they said, look, asthma is a disease of inflammation. And even in mild intermittent asthma, those patients need steroid to treat the inflammation. So they have 2 methods. They have basically two strategies of control. Long story short, and I'm going to go through this, ICS, or inhaled corticosteroid, and formoterol is the preferred reliever for patients prescribed maintenance and reliever therapy. Maintenance, there's an acronym that I'm going to use, MART, maintenance and reliever therapy. And then for other inhaled corticosteroids, LABA, that usually means salmeterol based. You need to use a short-acting bronchoagonist for your reliever. I'll go through this. It's a little bit convoluted, but the underlying principle, I think, is important and sound. This is the American version of the guidelines from the National Heart, Lung, and Blood Institute. They did an update in 2020. They basically also allow that low-dose ICS formoterol is an appropriate management strategy, but they also say PRN, concomitant ICS, and short-acting bronchoagonists. They have alternatives. Sometimes you'll go straight to daily glucotrain receptor antagonists or cromolyn. This tends to be more in the pediatric populations where you're concerned about ability to use an inhaler or compliance with an inhaler. Well, not just the pediatrics. but they're both moving. It's not surprising that they both had updates in 2020 that showed that inhaled corticosteroid and formoterol is in this case, one of the preferred strategies. In GINA, it is the only preferred strategy, although they accept the other inhaler-based strategies as a possibility. Okay, so just so you know, when I have a circle around two inhalers, that's supposed to be a combination inhaler. I use that just to avoid any sort of branding when I have my inhalers out there. Okay, so just so you know, so this is strategy number 1, intermittent asthma strategy. Basically, you blow right through that short-acting bronchodilator, and you go straight to a formoterol-based inhaled corticosteroid LABA, and you use it PRN. You know, and this is because a lot of patients were using their short-acting beta agonists. I keep doing that without the steroids, and there is actually significant data from 2000 on that causes some problems. I'm going to go through that data in a second. But they found that, you know, even if you're not really using it that frequently, that little bit of steroid seems to have a benefit. If you think about steroids, even though we take them twice a day most of the time, they probably are lasting 2 days, 3 days, sitting there in your airway. That's why for methacholine challenges, we're always asking patients to stop their inhaled corticosteroids 3 days, maybe even longer might be good, before their methacholine challenge. So if your patient starts to have more persistent symptoms, you basically advance therapy by changing from PRN to scheduled. It makes it so much easier. Your patient has one inhaler, they're used to it. They just take it every morning and every night instead of PRN. And just as it's not noted on here, but we start with the lower dose inhaled corticosteroids and advance to the higher dose inhaled corticosteroids. So you do the 80 and you move to 160. You can do 1 puff, 2 puffs, but it's all together in a nice neat package. Strategy number 2, you use your SABA and an inhaled corticosteroid. And this tends to be you don't want to use a combination bronchodilator that doesn't have formoterol. Does anybody know why? Anybody online know why? I talk about this kind of ad nauseum if after a while you get. So formoterol has a dual onset of action. It has an initial bronchodilator action that takes, it actually is within 2 to 5 minutes onset. So the patients actually will feel some relief. Moving on to, and then of course the long-acting beta agonist component remains there for 12 hours. And so it does have a bronchospasm relief component. And then of course the steroids. Now the thing that's a little tricky about this strategy, which you don't want to use salmeterol because it doesn't have that fast-acting component, you have the steroid and the short-acting bronchodilator. The patient, say they don't take their short-acting bronchodilator very much, but along comes a diesel bus, they get caught, they take their SABA, 2 puffs, concomitantly, they're supposed to take their inhaled corticosteroid. So they're supposedly carrying around two inhalers all the time for every time they have their intermittent symptoms. This is really hard for patients to do. Now, if you can get your patients to do that, it is extremely effective. So your DPIs are going to still work. It's just that it's hard to get patients to be appropriately compliant with this strategy. Just to mention that, as if you haven't heard this already, SABA is not recommended for intermittent. SABA only is no longer recommended for intermittent asthma. So once it becomes more persistent, you advance your therapy, and you basically first you make your inhaled corticosteroid scheduled, and then you increase the dose of inhaled corticosteroid. Something's cut off down there, and I don't know what it is. Sorry about that. This starts to look like your usual asthma therapy. Later on, you combine it with an inhaled corticosteroid and a long-acting beta agonist, and that doesn't matter what type. If it's scheduled, doesn't matter which long-acting beta agonist you use. You may still need to use your SABA in this strategy, but you're using it with the steroid already on board. Of course, when things really get bad, we actually recommend, both strategies recommend addition of a long-acting muscarinic antagonist. This is, if your patient's at this level, hopefully they're seeing a specialist. This is considered to be severe asthma and they need to be on a LAMA. Okay, so for strategy number 2, I've already kind of said this, so I'm going to speed up, but basically, if your patient can't be compliant with the inhaled corticosteroid, this can cause some problems. So basically, if they cannot be compliant with it, carrying around the 2 inhalers for whenever they have their intermittent symptoms, they're basically following the SABA-only strategy. Well, what's the big deal with following the SABA-only strategy? Well, actually, there are some big deals. SABA-only, and this is data that's been accumulating and accumulating, it increases the risks of severe exacerbations. It's treating only the bronchospasm. It's not treating the underlying inflammation of asthma. And as we mentioned ad nauseum, inflammation is a sine qua non of asthma. So SABA, regular use of SABA without corticosteroid is associated with beta receptor downregulation. In other words, some resistance, what they call bronchodilator resistance, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response, probably related to beta receptor downregulation. And then the other studies, this is the Aldrich study, shows increased allergic response in atopic asthma only, increased eosinophilic airway inflammation. So if you have neutrophilic asthma, maybe not so much, but frequent, there's actually, at least in the lab-based rather than patient, or in the bench research as opposed to the clinical studies, we see these responses to SABA only. It's been confirmed in clinical studies. And then finally, this is kind of the psychology of getting people using inhalers. Frequent SABA use trains asthmatics and probably COPDers to consider it as principal asthma treatment. And so you've all probably seen that patient who's just sucking on their SABA, but you can't get them to use their controller therapy. It happens in COPD too. So, do we have time? Okay, we're almost out of time, and this is just a kind of a teaser for the next lecture anyway. When inhalers don't work, and actually it's pretty common. This is an illustration of how asthma does have some overlap with COPD. This is what we see at the VA a lot, actually. But sometimes you have to realize that, as I mentioned, there are imitators of asthma. Just be aware. That being said, there's also, we tend to focus so much on the eosinophilic version of asthma, we forget about the neutrophilic. But basically, first you have to think of non-pharmacologic strategies when you notice the inhaler's not working. First, you have to assess your inhaler use and technique, not yours, your patient's. Address those comorbidities I mentioned. GERD is a big one. There are some patients who don't seem to have any, they don't seem to have eosinophils, they don't seem to have neutrophils, but they have GERD. And that GERD is causing inflammation, so you need to treat the GERD. And as I mentioned, they may say they have no GERD at all. I don't have any heartburn, doc, none at all. And it tends to be non-acidic GERD, but it still causes inflammation and causes problems. So you need to treat it, address their allergies. Sometimes you need to send them to an allergist. Sometimes they're smoking. Well, that's the world we live in. And then you need to address their environment, their workplace. I had a patient who was a painter. And if you don't have time to do a good history, you can miss this. It's hard, but the patient's, oh yeah, my asthma stinks, but then I went on vacation and my asthma went away. And you realize he's a painter and those VOCs are causing some problems. Or other chemicals, of course. You want to revisit other imitators. Just start looking for, get X-rays, get ANCAs. Basically revisit that long list of imitators I mentioned, and then consider other pharmacologic options. And this is the last slide. Azithromycin, we use it a lot in COPD, but I have never really promoted it as an asthma therapy because, but it is an asthma therapy. It's very useful actually in both eosinophilic and neutrophilic asthma. And so occasionally you may end up giving patients azithromycin. It's recommended 3 times weekly, and COPD it's kind of moved on to the 250 daily. But in asthma, the guidelines still say 3 times weekly. It reduces exacerbations, and the data is only in high inhaled corticosteroid LABA inhalers. We don't know about the moderate or minimal as well. Now, you can use, I do not recommend this, the guidelines do not recommend this, but sometimes you can use systemic corticosteroids. This is usually in the patient who has no insurance. And unfortunately, this is still a reality in the United States. It's cost effective. It is not recommended. I work really hard to get these patients off steroids. They're referred to me on steroids, and I spend my days getting them off steroids. It's so painful. And then the final step are biologics, and that's going to be the next lecture. One last thing, I guess it wasn't my last slide. Don't forget to do an asthma action plan. There are asthmatics who are frequent exacerbators and asthmatics who aren't, but an asthma action plan can save lives. It's actually much more, it's better validated in asthma than in COPD. And even a patient with mild asthma can have a severe and dangerous exacerbation. So because you have so much free time in your short visits with your patients, do your best to go over it. It's actually the best time to do this is when the patient comes into the hospital with an asthma exacerbation, but of course, ideally you prevent that exacerbation. The key thing is though that patients, especially the patients who don't necessarily sense their asthma or are stuck on their rescue inhaler and forgetting to use their inhaled corticosteroid, if they get to this area where they're using their SABA a lot, they have some symptoms, you want to train them that a little signal goes off in their heads. Caution, you need to pay attention. And sometimes a short visit to the doctor's office can't do that. But if you write it down for them and you say, stick this on your refrigerator, or if you treat pediatric, get your mom to stick it on the refrigerator for you. Sometimes that little warning light will go off in their mind and they'll say, oh, something's going on. Time to get help, especially if it's not better in one day. And of course, hopefully they're going to notice this. But remember, my friend, the medical student, did not recognize this and passed out in her home. So sometimes you just have to write it down for patients, and then it'll take hold. Sometimes it doesn't, unfortunately. I just want to mention there's some decent resources for oh my gosh, here we go. Asthma, I don't know why I have both the COPD and asthma, but asthma, the www.ginaasthma.com is the GINA website, the NHLBI asthma guidelines. This of course includes the 2020 update. ATS has a great asthma center. There's a lot of resources, including printouts for patients that you can give them. There's a lot of allergy resources, which we kind of, I don't know if there's competition or what, but there's a lot of allergy resources too, and your local allergist can be a resource as well. So even though I don't have it up there, and I will, for the next lecture, I will fix this, there are allergy resources as well. Okay, and that's it. I went right up to the deadline. Any questions? Any questions out there? And let's see if I can, I'm going to see if I can find the chat. Well, let's see if it's going to let me do the controls.
I don't see anything in the chat, Dr. McKell.
Okay, thank you. All right, you guys know where to find me if you have questions. So we'll talk about, you'll hear more about asthma.